I have an interesting case of a patient who had failed a surgical bypass for toe gangrene, for which I did a composite sequential bypass on 2 years ago. He had stopped taking all of his antiplatelet and anticoagulant medications because he needed multiple tooth extractions. So he's off all medications for 3 months. And he presented to my office with rest pain, which had been going on for the past 3 weeks. His prior anatomy was such that he had a femoral popliteal occlusion coming flush off of the SFA. He had an at-knee popliteal artery segment with like a blind popliteal segment, and then he recanalized in the posterior tibial artery. He did not have enough saphenous vein for a full femoral distal bypass, so I had done a common femoral to above knee bypass with PTFE, and then off of the PTFE bypass, I took a piece of saphenous vein to the posterior tibial artery, which worked well during that time. However, when he came back with his rest pain, I brought him in for angiography, which demonstrated he again had a flush SFA occlusion. There was some recanalization of the blind popliteal segment, and he had some distal reconstitution of his posterior tibial artery distally in its mid segment, which you can see in this run over here. Let's see. My apologies, for some reason it's not playing, but it came back basically just above the ankle, the posterior tibial. So what I did in this particular case was got right femoral axis from up and over, upsized to a 6 French sheath, and tried a navicross. I was able to get into the flush segment of the SFA. However, due to dense calcification, I could not pass down to the occluded segment at the knee. So then I went with retrograde axis from the posterior tibial, using a 4 French microcatheter. And then from there, I was actually able to use an 014 glide wire advantage, which was able to pass from below. And what I did was I was actually able to get it all the way through that segment and snared from up and over. There were several times I needed to balloon. I started first with a 4 millimeter balloon, then upsized to a 6 for several different segments. Repeat runs had shown that there was still severe stenosis. So during that time period, I had also done some jet stream to remove any possible thrombus that was there. However, this was all mostly calcific disease. You can see that there's still some, definitely a lot of spasm and stenosis present. So during this time period, I used a Eluvia drug-coated stent for the top, and I used a Supera towards the joint for that area, which basically was able to recanalize the femoral popliteal segment. And then from below, I used a drug-coated balloon at the joint itself, and basically an angioscope balloon for the posterior tibial. There was some spasm at the end. However, he had a strong Doppler signal present, and he's basically had relief of his rest pain since then, and it's been 5 months now. And just as a review, I was an investigator in the Imperial trial, what I basically used the Eluvia stent for was to try to correlate with the long segment disease of high patency at basically 12 months with Eluvia for femoral popliteal long segment disease. I incorporated that into this case as well. And so far, we're doing well. Thank you.